Good morning, everybody. Welcome to day 4 of the 2025 Within Health Summit. I will give everyone just a few moments to transition from the waiting room. Thank you for joining us. This has been a week full of amazing presentations, interesting content. Again, my name is Jamie Singletary. I'm the Senior Director of Clinical Brand and Community for Within Health, and I am so honored to be the host of this year's summit. Just want to give you a few housekeeping items before we get started with our talk this morning. Please remember that your CEO dashboard is your best friend. This is where you will find the schedule for today, along with your evaluations for each session. At the completion of the summit today, you will have the opportunity to download and print off your certificate. So make sure that you complete those evaluations, and then you will be given a link to download your CE certificate. If there are any questions or comments about the summit, I will have my contact information in the chat. If there's any technical issues that you are having, I will also provide CEGO's information as well. So without further ado, I will turn it over to my friend and colleague, Katie Peel.
Hi, everyone. I'm Katie Peel. I am a clinical lead here at Within Health, and I'm so excited today to introduce everyone to our fabulous presenters who are from the EDGI Training Project. The EDGI Training Project brings together 10 experts in co-occurring eating and gastrointestinal disorders with the goal of training other providers to deliver compassionate, effective care to clients struggling with both conditions. Their book, Comprehensive Medical Nutrition Therapy for Co-occurring Gastrointestinal and Eating Disorders, provides an overview of scientific evidence on the conditions and best practices for nutrition assessment and interventions, all through a trauma-informed, weight-inclusive framework. Healthcare providers can earn continuing education units with EDGI Training Project through completing the book or attending online trainings. Learn more about these opportunities at edgytraining.com and at EDGI Training on Instagram. And it is my pleasure to introduce you to our two presenters today. The first is Dr. Jordan Shapiro. Him. He is the owner of Gentle GI, a trauma-informed gastroenterology practice in Houston, Texas. Dr. Shapiro completed his medical school at the Medical College of Wisconsin, residency in internal medicine and pediatrics at the University of Cincinnati, Cincinnati Children's, and fellowship in gastroenterology and hepatology at Baylor College of Medicine, where he also completed a Master of Science in Clinical Research. His areas of clinical expertise include GI complications of eating disorders, disorders of gut-brain interaction, inflammatory bowel disease, pelvic floor disorders, and transition from pediatric to adult care. Dr. Shapiro continues to contribute to the field via multiple peer-reviewed journal articles, book chapters, podcast interviews, and invited talks at conferences. Dr. Shapiro loves to spend time with his son, garden, cook, and stay active, and play guitar. You can connect with him at thegentleg.com, at gentle.gi on Instagram, and at Dr. J. Shapiro on X. And our next presenter is Janelle Smith, MSRDN CEDS, she, her. She is a registered dietitian, nutritionist, and certified eating disorder specialist with lived and clinical expertise in supporting a peaceful relationship with food amid gastrointestinal distress. She is advancing eating disorder informed care with the GI field in the GI field at her position with UCLA Health Digestive Disease Nutrition Program, the EDGI Training Project, and Dietitians and Gastrointestinal Disorders in the Academy of Nutrition and Dietetics, in addition to speaking at conferences and publishing peer-reviewed research on the overlap. She enjoys playing fire trucks and baby dolls with her two kids and partner in sunny Southern California. And you can connect with Janelle at www.janellesmithnutrition.com. Welcome, you two. Thank you so much for being here at our conference this year. I'd love to hop in. Where would you like to start?
Thank you so much for having us. Within Health, I think, has just been such an amazing connection and support system to make, and so we're grateful to be here and share, what we can do and collaborate.
Absolutely. Thank you so much for having us.
Wonderful. So, how do eating disorders and gastrointestinal conditions commonly overlap? Can you tell us a little bit about that? And what are some of the biggest misconceptions providers might have about this intersection?
Do you want to start, Janelle?
I thought you were going to take this
Oh,
one.
that's right. Yeah, we had a whole order. Yeah, I mean, we can both try, but it's interesting being on the gastroenterologist side of things because one of the beautiful things that I think a lot of providers don't realize is, as a GI doctor, when somebody comes to me with an established eating disorder and they have a whole team, my job is just to answer the gut specific questions. But it's a two-way street. I think we see patients who have GI conditions first, celiac disease, Crohn's disease, IBS, irritable bowel syndrome, that is, who develop disordered eating. And then it's a very delicate thing. Sometimes the standards of care for some of those, like elimination diets, can push somebody off a cliff into an eating disorder. And then we see the opposite too. And I spend a lot of time in my practice seeing patients who have established eating disorders who end up in what I call jail, because almost every part of the gastrointestinal tract can be impacted by eating disorders. And so sometimes even when they get to the point where psychologically they want to get into recovery and eat, they have symptoms that are keeping them from doing that. And so it's this dance, and definitely a two-way street that we see. And I'll kick it over to Janelle for any of her thoughts, but I think you could go through every organ system and talk about kind of the complexity of why people get feelings of early satiety, why they get nausea and vomiting, why they get pain, why they have trouble pooping. That's a lot more complex than meets the eye.
And part of how we all got into this project is, those of us who have worked in eating disorder care are so familiar with the line, your gut will heal through better nutrition. Just weight restore, just get through this time period, and a lot of things will be better. And in the GI practice, we see that that's not really the case. There are some things that get better, but in fact, more than 50% of people who are weight restored in eating disorder recovery continue to have GI symptoms and carry a diagnosis of a disorder of gut-brain interaction. So it's really important, I think, that we don't promise that treating the eating disorder resolves everything physically, but that there is this really complex, nuanced relationship between the gut and the brain that may be lifelong for those people with disordered eating.
Absolutely. I think that's a great point, because I get a lot of patients where they've done all the work and they're not better, and there's frustration and there's anxiety over, well, then what is this? I think two of the things we probably see the most are the early satiety, and that can literally just be a reflex in the stomach, nerves gets thrown off, where they eat, and instead of accommodation happening where the stomach makes room for food, it doesn't. We see that after post-infectious, gastrointestinal distress. So something just shocks the nervous system of the gut and it doesn't recover. The other one is constipation. In a lot of those patients, the thing that gets missed is actually a component of it, which is pelvic floor dysfunction, where those muscles, the overall motility is fine, they just can't get it out and they're struggling even when it's soft. This is early to talk about poop, but what were you expecting? And so, some of those patients need pelvic floor physical therapists. And that's delicate because a lot of patients' entry into the eating disorder world is trauma related. And so I think it's such a complex thing to get to try to pick apart. And obviously can't do it as a lone person in any field. So it's great getting to work with the team we have.
Would you be able to speak a little more about the interplay between trauma and sort of gut motility or gut symptoms?
We definitely see that individuals with early adverse childhood experiences are more likely to have a disorder of gut-brain interaction, and something that in the GI field we call visceral hypersensitivity, meaning that the enteric nervous system, the nervous system that's in the gut, is intimately connected to the brain and the central nervous system. And it actually, really holds attunement and guarding and um, hyper arousal due to past history of trauma. And this can really manifest every time we eat or every time we feel a sensation in our body.
Mm.
Jordan, what did you want to add?
Yeah, I think some of this, when you hear this term disorders of gut-brain interaction, so the most common one of those that we think about is irritable bowel syndrome, where, by nature, there's sensation abnormalities where things hurt, but you can't find it on a CAT scan, you can't find it on an endoscopy. There are motility issues where things move too fast or they move too slow. And so I always think about this like, these are the most common disorders we have, but as a field, we're bad at managing them, I think, overall in a non-eating disorder population. In the eating disorder population, I think there's even more sort of stigma towards these conditions, and patients often come. I'm usually like third, fourth, fifth GI doctor they've seen. They've had all the tests done, and they're like, nobody can figure this out. And the answer is sort of sitting there, but they've been dismissed and gaslit, and so it's a bit challenging. I think the one other thing that is so hard about these disorders is while you can't find them on a given test, um, the general eating disorder education for like a GI doctor, I did, internal medicine, pediatrics, I got some there. The only talk I got in 4 years of fellowship was a grand rounds I chose to give on it because I too have lived experience. I was really good at my eating disorder for about 12 years. And so the teaching is classically catastrophic things. It's like you purged and you ruptured your esophagus, or this condition called Boerhaave syndrome. Those things that are catastrophic can happen, um, but they're so much rarer than just like what Janelle was alluding to, motility issues where things are too fast or slow, or things hurting in the absence of like a clear inflammatory or structural process. And we don't talk about that. And the last thing I'll say is, and I feel like I'm the first byproduct of the EDGI training group. I was an early adopter. I basically got to immerse myself in a group of like 8 dietitians and a psychologist who I feel like have trained me well. But 98% of patients with an eating disorder have some sort of gut issue. So when you look at the scope of this, it's almost everybody at some point in their journey, and you know and in a population that doesn't necessarily want to run out and go see another GI doctor after they've often had bad experiences.
Some things that we've found are really essential are not even weighing in a GI appointment. It's completely irrelevant. Um, Not necessarily putting an emphasis on body size, but more on the connection between the gut and the brain and how we nourish ourselves, how we feel when we nourish ourselves, if we're nourished adequately or inconsistently. Those could be less stigmatizing ways to talk about the relationship between nutrition or undernutrition or ED behaviors. And need to be really sensitive with GI disorders to the tendency for people with a history of trauma that they're going to self-blame and internalize this as something that they did wrong. And so, I think gastroenterologists and GI dietitians can really emphasize the fact that the GI tract is very, um, what's the word? It can heal.
Resilient.
Thank you, resilient. Just like our general nervous system is that it can get better, and this is not something that they chose to do.
Yeah.
So it sounds like you both take a really trauma-informed and weight-inclusive approach to how you sort of conceptualize um, client care and work with folks with co-occurring ED and GI issues.
There's
Right.
no other way.
Yeah.
Love to hear it. Love to hear it. Any more sort of from like any more to say? I mean, so much more to say about that sort of intersection of weight inclusive care and trauma informed care.
I love when Jordan or Dr. Shapiro talks a little bit more about the rectal exam, the pelvic floor dyssynergia, because I feel like you are so sensitive to that, hence gentle GI, trauma-informed GI. So I don't know if you want to just
Yeah.
say how you have that conversation with patient.
Yeah, I think one of the hardest things is a lot of the GI like disorders of gut-brain interaction and eating disorders, when you look at the things that lead into them, there's a lot of shared risk factors, including trauma. And so it's when I see a patient, and it's often they're concerned about bloating, right? And there's sometimes you get the photos where it's sideways and they're like, I look pregnant. And sometimes you can see it, sometimes you can't. But it's a very distressing thing, I think, to especially for people who have some body image or body dysmorphia and concerns about that and history of being very sensitive to that. So, bloating is a common thing that comes up, and constipation, and feeling like I go to the bathroom and I can't get the stool out all the way. Like some of it comes out, or I'm pushing a lot. Um, and then it's really I think constipation and like stuff down there is just sensitive in general, because you don't know going into a visit, did you have a history of sexual trauma? Did you abuse laxatives where like you're like, these are I can't touch those, like these are off, right? There's such a like shame and blame. So I will often, when I get to the point where we're moving towards an exam, I will let them know, sometimes it can be really helpful to consider doing like testing for why you're having a difficult time pooping. And the easiest, quickest thing to do is a rectal exam. And even in saying that, like I can see body language. Like I've had patients curl up on the table and like their eyes get really big. And I'll say, I'm not suggesting that we start with that today, but I just want to explain why at some point in time this could be a really helpful thing. And I'll explain how, the muscles are supposed to, when the rectum fills with stool, gives you the urge to go, and it also reflexively relaxes the internal anal sphincter. And I'll make a little joke and say, thank God that's contracted and squeezing at baseline, or we'd be pooping all over the place when we go to the bathroom. But it should relax, and then if you squeeze down there like a kegel on the backside, you have control over that external anal sphincter. That's a skeletal muscle, just like your biceps, and you hold until you go to the bathroom, relax, push, stuff comes out. And in a lot of patients, what happens is those just get clumsy. It's nothing you did, but those nerves just get a little clumsy where you feel the urge to go and you push and they don't relax, or they even get tighter. And so we can feel that on exam. And a lot of patients at that point in time, after reading body language, I'll say to them, pretty much all my patients, one of the things I ask all patients about, because the last thing I want to do is cause additional trauma or re-traumatize somebody if they've had a history of sexual abuse, is to ask whether that's part of your story. And in when it is, or when I get a sense that they're really anxious about it, I will often give some alternatives. One of the things we could do is try some gentle laxatives. And I will have an open conversation and say, listen, if have some patients have a history of abusing these to purge, or sorry, not abusing, but using these to purge. Is that something you've ever dealt with? And even if they say yes, it's not a hard no for me. It's a, will you promise me that if you ever feel like you're moving towards that, that you reach out and we rediscuss? Because it's all tangled up, right? If they're not emptying, they're uncomfortable. If they're uncomfortable, they're not eating. And that becomes a threat to their eating disorder recovery. So I'm pretty aggressive in trying to use medicines and things to get people better. The last thing I'll say is, because the first line of treatment for pelvic floor dysfunction and dyssynergic defecation specifically is pelvic floor physical therapy, I have 4 female, very trauma-informed physical therapists. I trust their exams, and I will often tell patients, if I have a high concern for that, would you be open to a female like therapist who's really knowledgeable with this seeing you? They may not even do internal exams or work the first time. And if they're open to that, so they just have one exam, I'll ask permission to share just high level details. And many of the times those patients do fine with an exam, and sometimes they choose not to go that route for the first 1 or 2 visits with them. But it really gives them control and choice but it also acknowledges like we don't want to ignore something that could be a really big part of your symptomatology. And I always use the jail thing. I'm like, you didn't choose the eating disorder, it served a purpose. Let's talk about that even. Now we're reaching a point where it's, you know, harming you, it's causing you troubles, and you're trying to process and get through this and work with your team. We need to make sure that your GI symptoms don't keep you from achieving those goals. And so, sorry, it's a long spiel, but it's such a dance of kind of a lot of things, I think, when you're in those situations that are so sensitive.
I love the spiel. I want you to keep talking about it, but I'm gonna ask you another question that's hopefully related. So what are some red flags providers should watch for that might indicate a client's GI symptoms are being impacted or even maybe masked by an eating disorder?
I think when the symptoms are not getting better with a standard GI intervention, that can really indicate that there's an underlying um, kind of relationship with food that may be perpetuating the symptoms. Um, Certainly, if a patient, I think it's important that we ask in GI encounters, um, if there are any disordered eating behaviors, and some people are very honest and some aren't ready, and that's okay. Sometimes, esophagitis, gastritis, difficulty swallowing can be related to eating disorders. Certainly, constipation, bloating, diarrhea. Any red flags that you thought of, Jordan?
Yeah. I think that there's the red flags that those two things are impacting each other. I think general red flags that um, we think about where you don't. The other way of looking at this or asking a question is like, how do you make sure that you're not sitting back and saying, oh, this is just the nerves of the gut and the microbiome of the gut being impacted by an eating disorder? Like, what are the things that, like, if you're in eating disorder care, you should seek out the care of a gastroenterologist? Would be things like, if there's blood in the stools. I think if somebody has like persistent nausea and vomiting where it's like so severe that simple nausea medicines are not helpful. I think like severe abdominal pain. Um, those are a couple of things that I think I always worry about. For me, though, the things that kind of flag are if somebody is starting, when I start asking a diet history and they've been through like the whole, right? Like they've tried to heal their world with lifelong vegetarian because of the way I was raised, but like, somebody has tried to heal every problem with diet. Like that's their first go-to for everything. Um, that starts to raise some concerns that this person's first thought is just restrict. And some of those are patients where they're disordered eating. They're maybe not, they haven't had a full-blown, eating disorder, but they're definitely at risk for getting there. But I have pretty open conversations with patients about it. It's one of the very few things that I, at times, like will self-disclose to patients, especially if I feel there's like a lot of shame around it. And I'm just like, and again, I always go back to soften it because it's a hard thing for people to talk about, especially males, I think. Picked up so many males who came for one thing and it's like, I'm worried about this. But I will always tell them, in veterinary medicine, like if a bird is plucking all its feathers out, we're really quick, like, or veterinarians are very quick to go, oh, gee, evolutionarily, like what might have been adaptive about this behavior? And in humans, we're so quick to blame and go like, how could you do that to yourself? Whether it's alcohol or it's an eating. And I think just starting with like this soft, safe curiosity, like in your life, eh, what made you need this at some point in time, or how did this arise to maybe even save you from something, and how might it have become maladaptive or harmful over time? So um yeah.
In males, are you seeing different presentations and symptomology at all in your male identifying patients with eating disorders?
I think at least in my experience, yes. It's a lot of I seem to be on this like run of like bodybuilders and fitness models who are showing up in my practice, and they're really bothered about bloating. It's like, I'm going to a beach in Jamaica, and like I think I have SIBO or small intestinal bacterial overgrowth. Like I want antibiotics because I want my stomach to be flat. The last one, that I picked up and ended up referring to an eating disorder treatment center is doing great. And it was super early. It was like constipation, but there was something that didn't make sense because he came for that with his adoptive mom. So had some adoptive trauma, super loving mom. And like at the end of a really long visit was like, actually, I'm not constipated. I'm in the bathroom because I'm vaping. And I was like, okay. But then at the end, when I had her step out, so I mean, the American Academy of Pediatrics, I see patients 15 years of age and older, like 14 and up, they're like, you should have the parents step out just to get them comfortable with interacting with healthcare professionals. It's not all, I tell patients, it's not only to talk about sex, drugs, and rock and roll, but also we're going to talk about that. And he started sharing how he was on Instagram, and he was just, he had lost 50 pounds. He was getting a lot of positive attention from people, from females that he was interested in, from sports coaches, and it was just a lot. And he was talking about how I asked him about social media, and he said, "Yeah, I get on there, and I'm just like, these are like my role models." And I said, "I'm just gonna tell you right now, we need to really be cautious and just aware of the potential for this to keep going to a really unhealthy place." So I was like, I don't want to take away the hard work you've done, and also just trust me on this. So his mom brought him back 3 months later, and she was like, I think you hit the nail on the head last time, because he had lost 25 more pounds, had EKG changes, was like having pre-syncopal events where he felt like he was going to fall over. So I think that was my story. I was an athlete, I was in a bigger body, and I had these images projected in magazines that was like, this is healthy. And I got applauded for, the changes that I had made. And it got to the point where I was like so emaciated that I like didn't have energy to like run up and down the court or around the bases. But it started with so much like positive validation that I kept going, and I didn't know how to stop. And so I see a lot of that in males, and a lot less talking about it openly. Like I don't think like men tend to get together and be like, look at my abs, look at my calves. Like, I don't know, like there's just less talk about like body types around male groups, and it's a lot more closeted. So I don't know. I feel like it's sort of my duty when I have male patients, and I'm like, been there, I get it. So
Sure, for sure. Janelle, any of your own thoughts about male development of eating disorder and GI symptoms?
I agree that I see bloating be an increasingly prominent issue. And, always ask how much of that is related to how you look, and how much of it is about how it feels in your body. And so it can be really helpful to acknowledge the both and to not say it's just one or the other. It can be both very uncomfortable, but it could also be very shameful or embarrassing. And we need to do a lot of work in destigmatizing that and helping people tease that out so we can prevent more disordered eating.
I have a sort of like maybe out of left field, but not so far in the left field question. But just listening to you both sort of share, um, I have like and the prevalence of GLPs. Um, I know that one of the side effects of GLPs can be slowed motility, and maybe some nerve interaction in the gut. Um, and I feel like this is one of those like the field had a lot of knowledge in, or not a lot, but some growing knowledge in the intersection of GI distress and eating disorders and sort of the co-occurrence of these things. And now so many folks are on a GLP, and that's sort of a curveball. How are you seeing GLPs impact all of this amazing research and practice that you are doing?
A ton. I'm getting tons of referrals of someone who has developed GI syndromes because of the GLP-1. Um, I think it's important that we be very like patient-centered and whole person when we approach this, and see kind of what are the benefits of the GLP-1 for that person, and also not to dismiss or applaud the changes that mimic malnutrition and anorexia. Like we're literally inducing anorexia in a lot of people. Um, and I'm seeing all of the physical and mental consequences of that in people who did not have at least that presentation before the GLP-1. Um, I think, unfortunately, in the GI field, there's a bit of like assumption that slow motility is normal and okay due to a GLP-1, but we need to keep monitoring how that impacts that person's nutrition status and quality of life and um, eating pathology in terms of, their mental health.
I agree with all that. And I think like in general, though, like I've had so many patients who've had gut issues, even though it's become like more where their primary, whoever was prescribing it downplayed like how frequent they are. And granted, I mean, we're in a very biased position because we get the people with issues from it. But it's actually really, really common. I mean, from esophageal like trouble swallowing to gastroparesis to colonic motility slowing down where people are constipated, to pancreatitis. And I just think um, it's common. I had a patient recently who was actually getting like abdominal wall like trigger points related to injecting it incorrectly, and had gone through the whole like they were going to get you know their appendix taken out by a surgeon, and I was like, please stop. So yeah, I think it's common, and I think I always talk to patients, especially when all three of those things are intersecting. Like if you take the example, which is very similar, of like you go on a cruise ship and you get a stomach bug. Like most people, they get better. There's a small percentage they don't. They get post-infectious, like irritable bowel syndrome. Why is that? Well, some of the risk factors are, female, somebody with a history of anxiety, depression, trauma, really severe initial infection, getting antibiotics, because all those things like antibiotics are a hit to the microbiome. So I always talk to them about like cumulative hits, right? So you've got history of an eating disorder that even if you recover, you're a little vulnerable, whether it's a stomach bug or it's an antibiotic, or it's not to say you can't have antibiotics, just to say, you may be a little bit more likely to have that second hit push you into more ongoing symptoms. And so when you throw GLP-1s in there, I think it's another cumulative hit. And I definitely do feel like and I don't think there's data showing this yet. I don't think the study's been done, but I do worry more in patients who've had a history of gut issues from an eating disorder, even if they've recovered, that they're going to be more sensitive to getting these on a GLP-1. Remains to be seen if that bears out in research, but I think about that quite a bit.
I think something that I've seen in practice is that the speed and the dose of the escalation, or the speed of the escalation of the dose, can make a
Mhm.
huge difference in terms of gut tolerance. And so if providers can acknowledge the long-term potential health benefits to metabolic health, if that's what the GLP-1 is being used for, then go slow. Don't induce disordered eating in someone for whom this could be a perfectly sustainable medication long term. We don't have to rush it. We don't have to create vomiting and laxative abuse.
Yeah,
So
I think that's. Oh,
so
go
go
ahead.
ahead. No, you please speak.
I was just going to say, I think that's part of the benefit of like multidisciplinary care for these patients, is that, in a given, visit, I'm obviously best when I'm asked, hey, this patient has these things. They have a therapist, they have a dietitian, they have an eating disorder, primary provider, and I'm getting asked, how can we manage the constipation as long as I have an awareness of how it all ties together? And so I think, similar to GLP-1s, one of the troubles in GI right now is there's a lot of there's an increase in what's called endobariatrics, which is actually like endoscopies that are mimicking some of the classic bariatric surgeries. So there's this whole, you know, I remember, I'll call myself out. We were having like a meeting about one of the chapters, and Janelle was actually the one who, I think I wrote something about GERD, right? Like gastroesophageal reflux disease, super common thing. And in the GI world, there is this piece of treatment, which in some patients, like a small amount of weight loss can actually like help with some of their symptoms, but there's biases in this side. And I just remember it was like one of our first meetings, and she was like, Jordan, I'm a little triggered with the way this is written. And like, I was just like, oh God, thank you. Right. Because like my field has pushed towards like doing procedures to help people lose weight, which means we're way on the other side of a balanced approach and weight neutral and weight inclusive approach to care. And so, I mean, I love it. I have it multiple times where I'm just like, I don't know how to word this. How do I say this to a patient? And I just have a slew of people who talk me straight.
Janelle, what are some of those throwdowns that you've presented?
I mean, and this is maybe some tips for eating disorder providers to collaborate with other people. Like having a relationship with people before you call them out can be helpful. Personalizing it, saying like, this is triggering to me, or this could be triggering to someone, with an eating disorder. Could we perhaps phrase it this other way? Can you hear me? I just want to check. You can.
Yeah.
Okay. Katie, I think, is frozen.
Maybe frozen.
Yeah. I share my assessment, my point of view, without saying this is the way it is, this is the way you should see it. And then I ask for their point of view and their assessment. And then I am upfront with saying, like, I'm worried that that doesn't encapsulate this other part of this person. Would you, this is what I would recommend, or this is something I'm wondering if you would consider. I mean, these are all very nice professional conversations. I will also just say, Jordan, that's weight biased, or that's fat phobic. And Jordan is very open to feedback, which is part of why we love working with him. And not every provider wants to be told that or is ready to be told that, but we can depersonalize it and say, this is my overall assessment. This has nothing to do with you, right? But could we perhaps approach it in a different way?
And it's
Wonderful.
appreciated. Yeah.
Any more to sort of say in the realm of collaboration between, dietitians, physicians, and mental health care providers, and how like multidisciplinary, interdisciplinary work really supports our clients with these co-occurring conditions?
I think setting up the patient for the referral can be really helpful, because they may have past, bad experiences, to say, I really encourage you to share this information with that provider. Like, they may have no idea. Can you check with the provider? Like, is that what they meant? Because a lot of providers give diet recommendations without asking questions or without checking how the patient took it. And if the patient tells the provider, when you said that, if they give them a feedback loop, a lot of providers are like, oh my gosh, I'm so sorry, I didn't mean that. And then they'll correct it. Now, other providers will like double down, like, yes, I mean, you have to eat nothing to get better. And that's a person to leave. but make it a relationship and a conversation, and date your providers. So I think that, like, it's important to build the connections and to kind of set the patient up for what to expect from this other provider and what to really share and focus on.
Right. We see so many providers offhandedly say lose weight, and instead what they mean is increase health promoting behaviors, but the shorthand for it is lose weight, which can be so detrimental, especially when weight loss is not a given side effect of increase of health promoting behaviors, but what you're really going after are the health promoting behaviors.
Yeah, and I think like for irritable bowel syndrome, like one of the, and fortunately, our national society has kind of they've made an effort to combat this. But I mean, the low FODMAP diet, which is this like week or 4 weeks of eliminating gas promoting foods and then adding things back. One, if sequentially, if you get better with the elimination, is just like a standard thing. And in most clinics, people get a pamphlet or a handout. And it's not this, this is 3 phases, don't stay in the elimination past 4 weeks. And you should, not do this if you have any history of disordered eating or an eating disorder. Nobody was screening. And so there is now like a clear recommendation in a white paper that before you do the diet, talk to them about it. And if they do, have a history of this should not be done without like a lot of consideration from an eating disorder dietitian. But I've had patients, who get put on those and they don't realize they're supposed to reintroduce like after 4 weeks, and they come back and they're kind of disordered eating, and they're like, I can't keep doing this. Like it helped, but I feel terrible. And yeah, it's so we tend to take diet as like a module, like it's a drug. Like, here's your pamphlet, go do the diet, instead of having these conversations to tease out, is this safe for you, as we would with a drug, right? So
Thank you so much. I know we've just got a couple of minutes left. I wanted to see if there are any questions that anyone watching might have.
Is it okay if I share my screen now, just for a little more information about EDGI Training Project while we're taking questions?
Absolutely.
Thank you. We offer 12 CEUs for dietitians for completing the book and the quiz. And then we have a book club going on right now with additional CEUs, but it can help you with processing the information and just being accountable for actually reading it. Because we all buy the book and say, I want to read it. And sometimes we don't.
Absolutely. It looks like an incredible CE to be able to engage in, especially that it comes with a book that you can refer to.
And I do think it's great for therapists and mental health clinicians and nurses, yes, who um, want to have a summary or a real like integration of all of this information in one place. For some people, some information will not be new and other information will be new, because it really goes over gastrointestinal disorders, treatment, interventions that are dietary. So maybe, the nurse isn't always the person who's recommending the diet intervention, but oftentimes they are talking about diet. And it's really important that everyone is aware of what is actually evidence-based diet advice and what is not. And we cover all of that in the book.
Wonderful. Everyone, please run out and get the book so we can all be well educated and support our incredible clients in their recovery journeys. Thank you so much, Janelle and Jordan, for joining us today. If everyone wants to take a moment before we move to our next presentation at 8 p.m. Pacific, 8 a.m. Pacific, 11 a.m. Eastern. Our next folks speaking are Alicia Cotner-Williams and Dr. Ronnie Lee, talking about risk reduction in remote care and innovations in ethics. And if anyone has any further questions, or wants to get in touch with our incredible presenters, Janelle Smith and Dr. Jordan Shapiro, please don't hesitate to contact them through EDGI.
Thank you for having us.
Thanks so
Thank you
much.
for being here.